Hello again, everybody, and welcome to part 10 of our internal medicine review questions. We'll be going through a number of questions here. Remember, again, pay attention not only to why the correct answer is correct, but also to why each of the wrong answers are wrong. And that's just general advice when you're going through your practice questions. Make sure and spend some time looking over the explanations. And another way that I would recommend doing this is to, once you're done, once you answer the question, even if you get it right, go through and make sure that you can reason why each of the wrong answer choices are wrong. Because if you don't know why the wrong answer choice is wrong, you are going to be at risk of falling victim to one of the distractors when you take your actual test. All right, so if you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, let's go ahead and start. We got a 35-year-old man coming in because he's got a rash on the right side of his neck. Last week, he was exploring a cave in Ohio. When he got home, he noticed multiple excoriations on his neck, which healed after a few days. Within a week, he developed a red bump on his neck where the excoriations were. The bump enlarged and began draining clear fluid with no odor. Now there are 3 erythematous nodules, approximately 1 to 1.5 centimeters in diameter. Adjacent cervical lymph nodes are normal and non-tender. He lives alone with 3 cats that sleep in his bed. Physical exam is otherwise normal and vitals are within normal limits. Which of the following is the most likely diagnosis? A. Histoplasmosis, B. Cat scratch disease, C. Blastomycosis, D. Sporotrichosis, or E. Coccidioidomycosis. All right, so let's go ahead and take a look at the answer here. And it is D, sporotrichosis. All right, now a lot of students have a hard time distinguishing between cat scratch disease and sporotrichosis. Now, these other 3, histoplasmosis, blastomycosis, and coccidioidomycosis, they tend to cause lung symptoms, pulmonary, respiratory symptoms. These 2, cat scratch disease and sporotrichosis, do not. So that will help you. So let's run through these. Histoplasmosis. Histoplasmosis, you may get a little bit distracted by the fact that this is in Ohio. Histoplasmosis tends to be in the Ohio River Valley, but it primarily affects the lungs. Usually there are systemic symptoms like fever, weight loss, fatigue. The skin really is only affected in disseminated histoplasmosis. So look for an immunocompromised person. But again, they're going to have pulmonary symptoms. We don't see that in this patient. We'll come back to cat scratch disease. Blastomycosis, again, primarily affects the lungs. This can affect the skin in ordinary people. If it does, you're going to have verrucous, wart-like lesions. They're not going to be ulcerative. Blastomycosis is in a very similar distribution of geography as histoplasmosis. And then coccidioidomycosis, this is endemic in the southwest U.S. and the desert. Again, primarily affects the lungs, but it also can have skin manifestations in ordinary disease and immunocompetent people. It will tend to cause erythema nodosum, and you should know that because there aren't a whole lot of things that do that. All right, so sporotrichosis, let's go over what it is first, then we'll compare it to cat scratch disease. So sporotrichosis is caused by a dimorphous fungus called Sporotrich shanki. It is found in decaying plant matter and soil. So you are going to get this by being outside, by gardening, by walking through the forest. It's everywhere. It's in soil. It's in decaying vegetation. So if you're outside, you can get it. A lot of people think, oh, you got to be a gardener. You got to be, working with flowers or whatever. No, you do not. You can get this from being outside. You get scratched by a tree, you can end up with sporotrichosis very easily. Of course, there are at-risk populations, gardeners, farmers, landscapers, anyone who's working with plants and soil. Manifestations, first you're going to get a papule. That papule then is going to get bigger. If it expresses drainage, it's going to be non-purulent and it's going to be odorless. This is a fungal disease, not a bacterial disease. What will happen, what makes this unique, is that you get this first papule, And then you'll start to develop more, and it'll come proximally because what it's doing is it's migrating up the lymphatic chains, and that's very different from cat scratch disease. Distant spread and systemic symptoms are very rare. When it does happen, it's in immunocompromised people. To diagnose this, technically you do need to do cultures. You'll culture it on Sabarod agar, just like most fungus. So cultures is where you'll start, and then you'll look at it under the microscope. It's got the very stereotypical cigar-shaped yeast with broad-based budding. I don't expect you'll be asked that. What you'll probably be given is the clinical vignette, and you won't be asked what is the diagnosis. You'll be asked what is the most likely diagnosis. The treatment is a long course of itraconazole, several months. Okay, so the difference between sporotrichosis and cat scratch disease. You've got to know this because they will test you on this. So one is fungal, the other's bacterial. Sporotrichosis, we talked about, typically comes from vegetation and soil. Cat scratch disease comes from a cat scratch or a cat bite. The symptoms. So with sporotrichosis, you get these nodules that kind of come up linearly. If you do have lymphadenopathy, it's going to be painless. With cat scratch disease, typically you'll have one nodule where the insult happened, the bite or the scratch. And then the more salient feature is going to be the regional lymphadenopathy, and it's painful. All right. Now, to diagnose this with sporotrichosis, you would do a fungal culture. With cat scratch disease, you'd do a Bartonella serology, and then the treatment. Sporotrichosis is itraconazole. Cat scratch disease is azithromycin. And remember, Bartonella Hensley causes a number of other things like bacillary angiomatosis in AIDS patients. So that's not the only place you're going to see this critter. Here's a picture of sporotrichosis. Notice how it's kind of got this linear distribution. Okay, question 2. We've got a 62-year-old man coming in complaining of difficulty achieving an erection over the past year. He is unable to achieve an erection during sex and also does not achieve morning erections. Past medical history is significant for hypertension, type 2 diabetes, dyslipidemia, and bilateral thigh and calf pain on exertion, which limits activity and goes away with rest. Medications include lisinopril, sertraline, hydrochlorothiazide, simvastatin, and metformin. He's got a 50-pack-year smoking history. Vitals are within normal limits. Physical exam reveals intact sensation in both lower extremities. Which of the following is the best next step in the management of this patient? A, obtain a ankle brachial index. B, penile Doppler ultrasound. C, prescribe sildenafil. D, discontinue sertraline and start bupropion. Or E, obtain serum testosterone levels. All right, so what is it here? A, obtain ankle brachial index. Why? Okay, well, first of all, he's got ED. The very first thing you need to ask a patient when they say, I can't have an erection, is do you have an erection when you wake up in the morning? It is very, very, very common for men to wake up with erections. You men know this. We know it, right? Women maybe don't know that. So it's important to know this. That's the very first question you need to ask when you're looking at a test question. It's something you need to know. Because if they get an erection in the morning, the arteries are fine, the nerves are fine, physiologically they are fine. It is more than likely psychogenic. However, this guy does not get morning erections, so it is probably organic. Usually it's going to be vascular, and when we look, he's got all the risk factors. He's got hypertension, he's got diabetes, he's got dyslipidemia. Oh, and look, he's got claudication too. So when we're looking at this claudication, then we need to know where it is. Well, where is he getting claudicated? He's getting claudicated in, let's see, where is it here? Okay, thigh and calf. So the claudication is going to happen distally to where the blockage is. If you have a blockage, let's say in your femoral artery, you're only going to get claudication primarily in your calf and foot. But if you have claudication higher up, let's say at the bifurcation of the aorta, then you can have thigh claudication. Now, it's also important for you to know that vascular claudication goes away with rest. And that is different from more of a neurogenic claudication, like from spinal stenosis, where that is not going to go away with rest. It is going to go away with position. Okay? So, very important to know. Why are these other answers wrong? Well, penile Doppler ultrasound, we really don't do that. That's just a distractor. Prescribed sildenafil, that would be great if he had psychogenic ED, if we did a workup and he's, he's fine vascular. Typically, that's something we give more for like an idiopathic ED. Discontinue sertraline, start bupropion. Certainly, sertraline can cause ED, and bupropion would be a great antidepressant to go to if you've got a male patient with ED on the sertraline or on an SSRI. But this is not being caused from the SSRI as far as we know. We're concerned about this being vascular. And then obtain serum testosterone levels. Probably not, because that will usually be in younger men who may have a low testosterone. So the number one thing we need to consider here is we've got to make sure that this patient has, that he's got good arteries, right? So beyond the erectile dysfunction, we need to make sure that we're taking care of his vascular health. So really, erectile dysfunction in many cases is a symptom rather than a disorder in and of itself. Now, in aortoiliac occlusive disease, which basically is exactly what it says, you will tend to see this triad. And when you have this triad together, it's called Leriche syndrome. Okay, now you don't always see this triad in aortoiliac occlusive disease, but you probably will have seen it in this patient. So limb and buttock claudication, often bilateral, diminished peripheral pulses, and erectile dysfunction. So I would know that triad. Risk factors, basically everything this patient had. The best initial test is going to be the ankle brachial index. That will tell you if you have peripheral artery disease. And all you're doing is you are taking the blood pressure at the ankle, dividing it by the blood pressure at the arm, and if it is less than 0.9, you have a peripheral artery disease. The management, we start with lifestyle modification, stop smoking, get blood pressure under control, take an antiplatelet agent, get them on statins if they've got high cholesterol. Supervised exercise therapy is typically done with that. After a month, after 2 months, if that is not working, we go to cilostazol and then ultimately surgical revascularization. Now, that being said, if you have limb ischemia, if you've got pallor and pulselessness and cold limbs, you are not going to go to lifestyle modifications first. You are going to get that ankle brachial index. You may get a Doppler, and you may start heparin right away or even go into surgery right away. But that's not this patient. So these are all the causes of erectile dysfunction. I've got a whole video on that. If you want to go watch it, I go through all of this. And these are some hints. You may be asked different kinds of erectile dysfunction because it really is a symptom. Okay, question 3. We've got a 46-year-old woman coming into the clinic due to incidental abnormal liver function tests discovered during a visit to the ED for diagnosed biliary colic 3 weeks ago. She was advised by the attending physician to follow up with her primary. She hasn't experienced any symptoms since her visit to the ED. She's got no chronic medical problems. She takes acetaminophen about 5 times monthly for tension headache. She doesn't smoke or use recreational drugs. She drinks 1 to 3 alcoholic beverages per week. She's married and in a monogamous relationship. Physical exams unremarkable, and then we have the labs. I'm not going to speak all of these. You can see them. So what is the most appropriate intervention for this patient? A, quantitative PCR for Hep B DNA. B, complete avoidance of acetaminophen. C, administer the Hep A vaccine. D, barrier contraception to prevent transmission to the partner. Or E, administer the Hep B vaccine. Okay, so what is our answer here? It is C.
Okay, so how do we know that it's not A? Why do we not get quantitative PCR for Hep B DNA? Because she doesn't have Hep B, right? She's got the surface antibody IgG. That is the antibody you will carry after you have been vaccinated for Hep B. And you should know by looking at the surface antigen, surface antibody antigen, you should be able to interpret that. I'm not going to run through that here, but I have a video on it. The surface antigen is negative, so she does not have active Hep B. She has been vaccinated, so that is out. Complete avoidance of acetaminophen, you don't need to do that. In a chronic Hep C infection, they can still take up to 2 grams of acetaminophen per day. That is safe. D, barrier contraception. So Hep B, that would be a good idea. Hep C tends to be transmitted only through blood. So IV drug use or contaminated blood products, it tends to not be associated with sexual intercourse. Hep B is. So that is out. And then administer Hep B vaccine, she's immune to Hep B. So it is C. Okay, question 4. We got a 52-year-old woman presenting to urgent care complaining of a cough for the last 8 days. Along with the cough, okay, we'll say man because I try to keep my questions gender diverse. So we'll say it's a man. He's experienced symptoms of nasal congestion and sore throat. The cough is productive of yellow-green sputum. He hasn't had fever, chills, night sweats, or weight loss during the course of these symptoms. No recent travel or sick contacts. He's never smoked or used recreational drugs. Past medical history is significant for hypertension and Okay, so this is a woman. Okay, just pretend I said she. Past medical history is significant for hypertension and postmenopausal vasomotor symptoms. Medications include lisinopril hydrochlorothiazide and paroxetine. Physical exam reveals scattered bronchi bilaterally. Remainder of the physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A, chest x-ray. B, discontinue lisinopril hydrochlorothiazide. C, oral azithromycin. D, oral levofloxacin. Or E, symptomatic care only. All right, so obviously must be a woman, postmenopausal vasomotor symptoms, which is why she is on paroxetine. Okay, so what is the answer here? Symptomatic care only. What does this patient have? This patient has acute bronchitis. And why do we know that? Because she pretty much only has a cough. Okay, a cough and maybe some upper respiratory tract symptoms, but no fever, no evidence of consolidation, no crackles, no increased breath sounds, just maybe a little bit of these upper respiratory tract symptoms. Really, acute bronchitis is really just a cough. That's pretty much it. It tends to be productive. It almost always is productive. Now, one thing I want you to get out of your brain right away, because I've seen so many people make this mistake, is that they think if there's yellow-green sputum, it must be bacterial. Wrong. You can have yellow-green sputum with bronchitis, okay? It's just mucus. So don't jump to bacterial when you see yellow-green sputum. It could be viral. It usually is viral. 90% of acute bronchitis cases are, in fact, viral. So why not a chest x-ray? Well, we're really not getting any signs of pneumonia here. Again, no fever, no evidence of consolidation. So that's out. Discontinue lisinopril. Lisinopril can cause a cough. It tends to be a dry cough. We don't know how long this patient has been on lisinopril. If they said she just started lisinopril and now she has a cough, well, maybe then. But that doesn't appear to be the case. Also, lisinopril is not going to give you a productive cough. It's not going to give you a sore throat and so forth. Okay, azithromycin and levofloxacin PO, these would both be good drugs for outpatient management of community-acquired pneumonia. You can use your azithromycin, you can use amoxicillin, you can use a respiratory fluoroquinolone, levofloxacin, moxifloxacin, gemifloxacin, but this patient does not have community-acquired pneumonia, so those are out, and it's symptomatic care only. I was just in the ER myself. I had a really nasty case of food poisoning over Christmas. And I sat in the waiting room for an hour and a half because the whole city was in for acute bronchitis. And I know it because I've heard it a million times. And so I had to wait while I was feeling nauseous and waiting for my IV medication because I couldn't keep anything down. It was great. My grandma currently has acute bronchitis. She's been coughing, 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 coughing. She's a little old lady. She's 98. She's on blood thinners. What do you think she developed? A rectus sheath hematoma, rupture of the inferior epigastric artery. So she is in a mess. We've had to reverse her Coumadin, but she's doing okay. So acute bronchitis, 90% of it is viral, various causes. The manifestation, it's a cough. It can be 5 days. It can be 3 weeks. They may or may not have purulent sputum. There are no systemic findings. At the worst, a low-grade fever, but that's rare. Wheezing or rhonchi may be present. There may be chest wall tenderness from the cough. The diagnosis, it's purely clinical. Really, it always comes down to is this acute bronchitis or is this pneumonia? And for pneumonia, again, they're going to look sicker. They're going to have a fever, always, always, always on a test question. If you think it may be pneumonia, your next test is a chest x-ray. Otherwise, acute bronchitis, treat them symptomatically. Any kind of red flag symptoms will warrant further workup. So if they're coughing up blood, if they're having a harder time breathing, certainly if they're losing weight, these are things that you'll want to do further workup if those are present. But in general, acute bronchitis, it's a cough, and that's pretty much it. Upper respiratory tract symptoms. Okay, question 5. We got a 30-year-old guy coming into the clinic complaining of hair loss, which he noticed 3 weeks ago, as seen in this picture here. There are no other areas of hair loss or thinning. Which of the following treatments is most likely to resolve this patient's hair loss? A, topical corticosteroids. B, intralesional corticosteroid injection. C, topical clotrimazole. D, oral griseofulvin. Or E, oral baricitinib. Okay, so this is a second order question here. You got to know what the condition is, and then they ask you to treat it. So it would be nice on the exam if they just told you, what's the diagnosis? Sometimes they do it. Other times you have to know the diagnosis, and then they're just asking you what the treatment is. Okay, so what is it? It is B, intralesional corticosteroid injection. Do you know what this is? What is the diagnosis? It's a condition my dad got about 20 years ago, and I was very worried I was going to get it. Alopecia areata. My dad is completely bald now. I never got this. I'm the age now that he was when he had it. So I'm hoping I don't get this. Now, one of the things that this is often confused with is tinea capitis, or ringworm of the scalp. Tinea capitis... let's go back to alopecia. So alopecia areata tends to look just clean old bald. So look at this guy. There's really nothing in the bald spot. It's just skin. Whereas tinea capitis tends to be scaly. The hair follicles are okay. The hair may have been broken. But what you'll often see are little broken pieces of hair, maybe black dots, which is just the follicle. You will see that in tinea capitis. With alopecia areata, you do not. So you can go ahead and look up tinea capitis. You'll see the scaling, you'll see the crusting, you'll see the hair. It doesn't look clean like alopecia. So limited alopecia versus severe alopecia, generally we're looking at 50%. If it's less than 50%, we consider it limited. If it's more than 50%, it's moderate or severe. For limited alopecia areata, the treatment is intralesional corticosteroids. If it's beyond that, then what you may do is a JAK inhibitor, and that was the baricitinib. So these answer choices: topical corticosteroids. This would be used in children with alopecia areata. You'd use topical corticosteroids. You probably won't get a question on a kid with alopecia. Topical clotrimazole. Would we use that for tinea capitis? No. We never use topical antifungals for tinea capitis. Tinea capitis, tinea unguium of the nails, we always use oral antifungals. So this wouldn't even be used at all. Oral griseofulvin, that would be the answer if this were tinea capitis. And oral baricitinib, this is a newer drug. It's called Olumiant. It's used for other things too. It's a Janus kinase inhibitor. But this would be if they had severe alopecia areata, or if, let's say, it didn't respond to intralesional corticosteroids or other treatment modalities, minoxidil and all the other things that you can do. That probably won't come up on your test, though. So if you get a question on alopecia, what they'll probably want you to know is how to distinguish this from tinea capitis. Okay, question 6. We've got a 50-year-old woman coming into the clinic after noticing a small lump on the front of her neck. She's got no other symptoms and says she feels like her usual self. No weight changes. Past medical history is unremarkable. She's on no medication. Physical exam is remarkable for a 0.5 centimeter mobile non-tender mass at the right lobe of the thyroid. Remainder of the physical exam is unremarkable. Vitals are within normal limits. Which of the following is the best next step in the management of this patient? E, CT of the neck. B, surgical excision of the right lobe of the thyroid. C, TSH and thyroid ultrasound. D, serum anti-TPO antibodies. Or E, thyroid scintigraphy. Okay, the answer here is TSH and thyroid ultrasound. That is always the initial test when you have a patient with a thyroid nodule. You want to know, is this a functioning nodule? If the TSH is low, this is probably a nodule that is autonomously spitting out thyroid hormone, and your TSH will be suppressed and it'll be low. Okay, so you want to know that. And then you want to look with an ultrasound. Why not a CT? Well, CT is actually inferior to ultrasound in detecting thyroid nodules, so that is wrong. Why not surgical excision of the right lobe of the thyroid? Well, this could be a non-functioning nodule, in which case you could just leave it be. So that would be premature. You only do this if it's confirmed cancer, which you would determine by a fine needle aspiration if you need to do it. So that's out. Serum anti-TPO antibodies, well, that would be something that you would get if you were thinking Hashimoto's. Hashimoto's has a diffusely enlarged thyroid, and they tend to have hypothyroid symptoms. So you would see a patient with weight gain and cold intolerance and dry skin and constipation and stuff like that. And then thyroid scintigraphy, this would be something that we would do after we get the TSH and ultrasound. So there is an order to this, and let's look at that. So when you've got a patient coming in with a thyroid nodule, of course, you're going to do your physical, but you're going to get a TSH level and a thyroid ultrasound. That is the first thing you are going to do. When you look at the thyroid ultrasound and you see any potential cancer risk factors, so we're looking at a really large nodule, a nodule of calcifications, a nodule if you turn your Doppler on with vascularity on the inside, those are cancer risk factors or suspicious findings. You would go to a fine needle aspiration if you see it. If you don't, look at your TSH. Like we said, if the TSH is low, that's pointing towards potentially a functioning nodule. And in that case, you want to know, is it functioning or is it not? If it is functioning, you probably already have a hyperthyroidism, maybe subclinical, in which case you would treat it. If it is a cold nodule, non-functioning, or if the TSH is normal, which is pretty much telling you it's non-functioning, then you do fine needle aspiration because either of these could be cancer. So if you've got suspicious ultrasound findings, if it's a cold nodule, or if the TSH is normal or elevated, you will do a fine needle aspiration. Know this algorithm cold, and it should make sense. If you think about it, it should become intuitive. Question 7, we got a 32-year-old guy coming into the ED complaining of severe generalized abdominal pain for the past 6 hours, along with fever, bloody stools, and malaise. He's not experienced any vomiting, but is mildly nauseous. He was diagnosed with ulcerative colitis 2 years ago, which has been controlled with sulfasalazine. He is not on any other medications. He does not smoke or use recreational drugs. He says he noticed some blood in his stool 3 days ago, and it's continued to now, but the severe abdominal pain is new. Physical exam reveals abdominal tenderness to palpation in all 4 quadrants. No rebound tenderness or guarding. Abdomen is tympanitic to percussion. Remainder of the physical exam is normal. Vitals are pretty much all within normal limits, except he's a little tachycardic, which makes sense because he's in pain. Which of the following is the best next step in the management of this patient? A, sigmoidoscopy, B, abdominal x-ray, C, abdominal ultrasound, D, stool studies, or E, methylprednisolone. Okay, the answer here is abdominal x-ray. Okay, so why is it an abdominal x-ray? What does this guy probably have? He's got ulcerative colitis, and now he's got a flare of symptoms. So he's got a UC flare. And when you've got a patient with a UC flare who's got severe abdominal pain, what you need to be thinking of is the potential for a toxic megacolon. Okay, and the reason that is so important for you to have to consider when you've got a patient with a UC flare is that a toxic megacolon can cause a perforation resulting in sepsis. Okay, so we cannot have that happen. The first thing you need to do when you've got a patient with a UC flare, especially if they're not pooping anymore, is you need to make sure they don't have toxic megacolon. So what do? We get an abdominal x-ray to do that. It is very easy. Now, sigmoidoscopy, would we want to do that in this patient? Absolutely not. In a patient that may have toxic megacolon, if we stick any tube up there, we might perforate and cause a serious problem. Abdominal ultrasound, really not particularly useful for abdominal pathologies, with a few exceptions. In children and pregnant women, we might use it to diagnose perhaps an appendicitis. Usually this is going to happen in younger people, but perhaps if they've got an intussusception, you would use an abdominal ultrasound for that. So that's not it either. Stool studies for ova and parasites. So that is probably not the answer here. The diarrhea is more likely due to the UC flare. You can get toxic megacolon from some of the pathogens that cause dysentery or amoebiasis, but that is less likely. And methylprednisolone, no, because we need to make sure that this is toxic megacolon first. So here's toxic megacolon. What you can see here is, one, you've got a dilation. Usually it's going to be more than 6 centimeters in diameter. But what you see more prominently here is the lack of haustral folds. You should see these folds coming in kind of like that, and you don't see it here. And that's really characteristic for toxic megacolon. Okay, so the abdominal x-ray we saw, we know it's toxic megacolon. Stool studies are negative for C. diff toxin. C. diff colitis can cause toxic megacolon, so you want to know that. This patient has not been on any antibiotics, so that is very unlikely. Which of the following would be of greatest benefit to this patient? A, mesalamine, B, opioid analgesics, C, emergency laparotomy, D, infliximab, or E, methylprednisolone? The answer here is methylprednisolone. Why? That is the drug we give for toxic megacolon. That you need to know that, okay? Now, why not these other things? Mesalamine, that is a 5-ASA compound. That is a drug that we could use for maintenance in a patient with mild ulcerative colitis, but this patient is having a UC flare. That is not a drug that we use to get them out of their flares. We use steroids to get them out of their flares. So that's out. Opioid analgesics. Do you think this would be a good idea in a patient with essentially a functional bowel blockage? No. So that is out. It would help his pain, but it would make his bowels very unhappy. Emergency laparotomy. Now, let's say we did that abdominal x-ray and we found air under the diaphragm. Then we would do a laparotomy. Infliximab, so this is used in the chronic management of ulcerative colitis, particularly moderate or severe UC, but we would not be doing it in the case of toxic megacolon. So the answer is methylprednisolone. We give steroids for toxic megacolon. Now, it's very important that you know that this is not C. diff. If it were C. diff, we would be giving antibiotics, okay? If you have C. diff colitis in conjunction with toxic megacolon, that is fulminant. That is fulminant C. diff. And in that case, we would give vancomycin PO and Flagyl or metronidazole IV, both, okay, in fulminant C. diff colitis. So here's your normal x-ray. You can see those nice haustral folds right there. You don't see them here. This is a severe case of toxic megacolon. So here you have it. This is what you need to know for toxic megacolon. Get the abdominal x-ray. If you have any reason to think that they have C. diff, if they've been on antibiotics, then go ahead and get that C. diff toxin. But if you got a patient with ulcerative colitis history and they're presenting like this, it's due to the ulcerative colitis. So we do steroids. You want to check their fluid status, their electrolytes. That's going to be important. Bowel rest. Obviously, if they have toxic megacolon, you don't want them eating. You don't want anything in their gut. So you might do an NG decompression, certainly NPO. Put them on D5 half normal saline. Antibiotics can be used because the risk of perforation is so high. Some physicians think it's a good idea to just start antibiotics right away. Those would be broad spectrum antibiotics. So think like Mirum or something like that. And then, of course, if there's signs of perforation or peritonitis, it is straight to the OR. Question 9, we got a 27-year-old guy coming to urgent care complaining of a sore throat for the last 3 days. In addition to this, he's also had subjective fever, malaise, cough, and headache. He has no significant past medical history and doesn't take any medications. Physical exam is significant for patchy white exudates on both tonsils, pharyngeal erythema, and palatal petechiae. There are 3 tender 1.2 centimeter lymph nodes palpable in the left anterior cervical chain. The remainder of the physical exam is normal. Vitals are heart rate 103, temperature almost 102 Fahrenheit. Patient states he's allergic to penicillin. He gets hives, no anaphylaxis. Which of the following is the best next step in the management of this patient? A, prescribe azithromycin. B, prescribe amoxicillin. C, supportive care. D, rapid streptococcal antigen test. Or E, monospot test. Okay. So the answer here is D, rapid strep antigen test. So you know we have this Centaur criteria, right? So Centaur criteria is fever, lymphadenopathy, and we're talking cervical chain or anterior cervical chain, and it'll be painful lymphadenopathy. A, absence of cough, and T, tonsillar exudates. Each of those are a point. This guy's got a fever. He's got lymphadenopathy. He has a cough, so that's not that doesn't count. And then tonsillar exudates. So this guy has 3 out of 4. And if the patient has 2 or 3 out of 4, we go to a rapid strep test. Okay, so you need to pay attention to this because it's a little different between adults and children, and you will be tested on that. So we talked about the Centaur criteria. You should memorize those. There is a modified Centaur criteria, but I don't think it really comes up on the exam. You should know these 4, though. If they have 0 or 1, don't test. It's something else. If they have 2 or 3, do the rapid strep test. And if it's a child, culture them too, because we're really concerned about strep throat in a child because they could develop endocarditis, they could develop rheumatic fever, lots of problems. Okay, so we don't see that so much in adults. So you need to make sure you're doing a culture for children. If you get a false negative, but a culture comes back positive, that's a diagnosis. And then if it's 4 in adults, treat empirically. You don't even need to bother. And that could come up because they may ask you, what's the best next step? If we come back here and we say he didn't have a cough, well, then he's got 4 of 4. And the next step then would be either azithromycin or amoxicillin. Either of these would be fine. You'd probably go with azithromycin for this patient because he's got an allergy to penicillin. Amoxicillin has a little bit of cross-reactivity, so I would go with azithromycin, but neither of these are right answer choices because he only has 3 out of 4. Now, in children, you will never treat empirically. You will always do a rapid strep test first. Okay, so that's the difference between adults and children. Adults, if they have all 4 center criteria, we can treat empirically. If it is a child, we always do a rapid strep test first. Now, some of you might be wondering, what is the difference between pharyngitis and mono? So let's say strep pharyngitis and mono. What you need to do on your exam is look at the patient's age. Mono will tend to be a teenager, let's say 12 to 23, something like that. They will also tell you usually that this has been going on for 7, maybe 14 days. They will also tell you a severe sore throat, right? But they may tell you the patient has significant lymphadenopathy, not only in the anterior chain, but also the posterior chain. They may have an axillary lymphadenopathy. Lymph nodes are very prominent in mono. And then the big giveaway is they'll tell you potentially they have splenomegaly, right? Now, in practice, it's often very difficult to tell whether it is strep throat or mono. And so we will do, in addition to the rapid strep test, we will also do a monospot test. We don't think it's mono in this case. This guy's a little bit older. He only has anterior chain lymphadenopathy. He doesn't have splenomegaly, and so we're going to think that the rapid strep test would be the one we really need to do. But in practice, you may do both. Now, something that may come up on your exam where they kind of trick you is it's not really tricking you. You need to know it. Is, let's say it looked like strep throat, you gave them amoxicillin, and then they came in with a rash. That is mono, mono, mono. Every time. Okay, so know that. If we said this guy came in after we gave him amoxicillin and he has a rash, you get your monospot test, it's going to come back positive, and you know exactly what it is. The reason they don't test mono a whole lot is because there is no treatment for mono. It is completely symptomatic care and avoid contact sports for a month. But you want to know, someone comes in with sore throat, you diagnose this strep, you give them amoxicillin, you give them ampicillin, they come in with a rash, that is mono. Every time. Okay, so here's kind of the algorithm that you can use. All right, question 10, one more. 52-year-old guy comes in with chronic kidney disease secondary to granulomatosis with polyangiitis, formerly known as Wegener syndrome, or Wegener's granulomatosis. He's been started on dialysis. He's got lisinopril and darbepoetin and an iron supplement. 3 months later, his hemoglobin's increased from 8.1 to 11.2. Which of the following complications is most likely to result from the drug used to treat this patient's anemia? A, constipation, B, hypoglycemia, C, hypertension, D, hyperkalemia, or E, angioedema? Okay, so the answer here, hypertension. Okay, so what is the drug being used to treat this patient's anemia? Darbepoetin. Darbepoetin is basically EPO as a medication, or erythropoietin as a medication. Very, very common for patients with chronic kidney disease to not make enough erythropoietin because that does come from the kidneys. So in many cases, these patients will need to be supplemented with darbepoetin. Now, a common test question is, let's say you got a patient with anemia, they need EPO, you give them darbepoetin, and their count doesn't come up, their hemoglobin doesn't come up, and they'll ask you why. And the answer to that is that they need an iron supplement. They're iron deficient. If you can give EPO, but if they don't have enough iron, they're not going to jump their hemoglobin. So that is something you need to know. But this is the drug that is given to stimulate erythropoiesis. So we know then that since this is the drug being given for the anemia, well, it's not going to be constipation. That would come from your iron supplement, but the iron supplement itself is not what's actually treating the anemia. If we said maybe they lost a lot of blood, they've got colon cancer or something like that, then the iron would be given. If darbepoetin wasn't part of this, then yeah, go ahead and say constipation. Iron can constipate the heck out of you. But that is not the medication being given for the actual anemia. We are giving darbepoetin, so that's out. Hypoglycemia, none of these things are going to cause that. Hyperkalemia, well, you can get a hyperkalemia with lisinopril, but typically it's not a very significant hyperkalemia. And angioedema is a very well-known potential side effect of lisinopril, but again, that is not a medication given for anemia. Now, why does darbepoetin cause hypertension? There are a number of mechanisms. It is believed to influence renin production. It is believed to increase sodium and therefore water reabsorption. It is thought to be a vasoconstrictor. So you put all those together, you can see how it can lead to a hypertension.